So hi, welcome everyone. So my name is Rugivan Sabaratnam. I'm a postdoc at the Steno Diabetes Center Odense, University of Southern Denmark, and Oxford University. And today I'm going to give you a very short introduction to two very complex chronic diseases, type 1 diabetes and type 2 diabetes. And later on, Morten from University of Southern Denmark and Odense University Hospital will give you an introduction to the diabetic bone. So, the diabetes is a major public health problem that is approaching epidemic proportions globally. Worldwide, the prevalence of the chronic are increasing at an alarming rate. For instance, 1 in 11 adults have diabetes. 1 in 5 people with diabetes are above 65 years old. 3 in 4 with diabetes live in low and middle income countries. So all these numbers are actually suggesting or indicating that it's so important to understand and identify the molecular mechanisms underlying these chronic diseases, because then it will be easier to target or produce targeted drugs that can prevent or manage these complex chronic diseases. So diabetes is a chronic disease that occurs when the body cannot, when the pancreas is not longer able to produce insulin, or when the body cannot make good use of the insulin it produces. So it is characterized by high level of glucose level in the blood, which is also called hyperglycemia. So there are mainly two forms of diabetes, type 1 diabetes and then type 2 diabetes. Type 1 is an autoimmune disease, occurs most frequently in children and adolescents. Whereas type 2 diabetes is the most common form in adults and accounts for around 90% of all diabetes cases. These two types of diabetes are also called polygenetic diseases. Thirdly, we also have gestational diabetes, which is a type of diabetes that consists of high level of blood glucose during pregnancy and is associated with complications to both mother and child. Lastly, I will also mention that we have also monogenic diabetes, which is any pathogenic gene variants leading to diabetes or syndromes, for instance, MODY or mitochondrial diabetes. So in MODY, you will have an impaired insulin production. In the mitochondrial diabetes, you will have a mutation in the mitochondrial DNA, which leads to diabetes. So as you all know, so in the beta cell, the insulin is produced. So when the glucose enters the beta cell, as shown here, through GLUT1, 2, or 3, it will get phosphorylated by an enzyme called glucokinase to generate a glucose 6-phosphate molecule. In the mitochondria, by an aerobic metabolism of glycolytic products causes high level of ATP-ADP ratio, which will then shut down the potassium channels, causing a depolarization and high calcium influx, which will then trigger the exocytosis and thereby insulin secretion. So this is a very simple figure illustrating the insulin signaling cascade. So insulin signaling is really needed to uptake glucose in the different tissues. So when insulin binds to the insulin receptor, you will have several autophosphorylation occurring in the receptors, and you have phosphorylations of IRS1 and IRS2. You will have recruitment of PI3 kinase, which is important to activate PDK1. So PDK1 will phosphorylate the AKT, which is the central molecule, and it's a key molecule regulating several important metabolic processes. So for instance, downstream to AKT, you will have AS160, which is a key molecule known to be important for the enhanced glucose uptake in the muscle, for instance. downstream to AKT, you also have mTOR, which regulates lipid synthesis and protein biosynthesis as well. And importantly, FOXO will also be regulated, which means that now we will inhibit the hepatic glucose production, mainly reducing the activity of gluconeogenesis. We also see that downstream to AKT, we have glycogen synthase kinase, which is a key molecule regulating or enhancing the glycogen synthesis. So altogether, it's also important to highlight that impaired insulin signaling is tightly associated with insulin resistance. I will come to this later in my presentation. So how do we actually evaluate glucose homeostasis? So in the clinical settings and also in answering research questions, two methods are widely used. The one is the oral glucose tolerance test, and the second one is the intravenous glucose tolerance test. So, but here I just want to highlight that when you go for a fasting state and immediately to after consuming a meal or something, you will have an immediately response of the beta cell, which means that you have the first phase of insulin release. This is really mainly to block the hepatic glucose production, so you can prevent the postprandial hyperglycemia. And second response is seen later here in the curve, as illustrated in the curve here. This is really important to reach the normal glycemia. So one of the problems with the OGTT is actually you can't really distinguish between the insulin resistance in the peripheral tissues and reduced insulin secretion capacity. On the other hand, the problem with the IVTT is, of course, that, for instance, as shown here, that this is in this method you will give a glucose bolus, which means that you will only detect the first phase and not the second phase here. But of course, you can use these methods in, as I mentioned, to diagnose the diabetes, but you can also use to estimate the insulin sensitivity and to less degree beta cell function. And the IVTT, you can of course also measure beta cell function and insulin sensitivity. But I really want to highlight that the gold standard to measure insulin sensitivity is actually using the euglycemic hyperinsulinic clamp. So in this method, what you do is that you infuse insulin at the constant rate at the same, which means that you will reach a condition called hyperinsulinemia in the body. At the same time, you will also infuse glucose so clamp means you infuse glucose, so you will keep glucose at the constant concentration. So therefore the name clamp. Euglycemic means that you reach a normal glycemia at certain points. So of course, when these two elements reach a steady state, it is estimated that 80% of the glucose disposal or uptake occur in the muscle. So this method is developed by Andres and Differenzo. And of course, in these settings, it's also important to note that the hepatic glucose production is of course inhibited. So because of the 80% of insulin-stimulated glucose uptake occur in the muscle, we and several others typically take a muscle before and after clamp. So here we see my mentor from Morten, so we actually take a muscle biopsy. So now we move on to type 1 diabetes. So this is a very simple figure trying to illustrate or highlight the possible key mechanism involved in type 1 diabetes. So type 1 diabetes is an autoimmune organ-specific disease, which means that the beta cell is damaged and is destroyed, and thereby leading to impaired insulin secretion. So some of the key molecules which are known to interact with each other is the CD4 T helper cells and the CD8 killer cells. And these will go together and destroy, together with the dendritic cells, the beta cells. And thereby leading to beta cell dysfunction. It's also important to know that the exposure of the beta cell to the the exposure of B cells to the beta cell autogenes will generate autoantibodies. So these autoantibodies are really useful in the diagnosis of the diabetes 1. So, but the key question is actually how and why you see an autoimmune response. So the mechanisms, of course, still investigated. So this is really to show that that in type 1 diabetes, the inflammatory lesions are observed in the pancreatic islet. So this is a hallmark in type 1 diabetes. So we have two immune staining from two different patients. In this condition, you see a much severe patient where you see it may not be very clear, but believe me that what I want to highlight here is that you have a high level of infiltration and mononuclear cells. But whereas in the less severe patient, you see a less degree of dendritic cells. So to summarize, type 1 diabetes is a chronic T-cell dependent immune-mediated disease, and it arises from genetic and environmental factors. Beta cell loss, of course, leads to insulin deficiency, and the autoantibodies may appear months or years before symptoms. One of the classical autoantibodies which are used to detect is GAD65, and onset often rapid in the children or slower in adults. So now we move on to type 2 diabetes, which is actually my research area. So here again, a very simple figure trying to really highlight that in type 2 diabetes, you have two key hallmarks. The one is insulin resistance, which means that you can't uptake glucose in key metabolic tissues such as muscle or adipose tissue or liver. And then you, of course, have beta cell dysfunction, which is impaired insulin secretion. The elements that contribute to insulin resistance and beta cell dysfunction are, of course, genetics and epigenetics. Being obese and physical inactive all contributes to development of type 2 diabetes. So we study muscle, particularly in my group back in Odense, and the reason why we study muscle is actually beautifully shown in this picture. And this is again from Diffronso from '87, which who clamped individuals with type 2 diabetes, and then we also have healthy controlled individuals. What we see here, if we start with the controlled individuals, is that relatively speaking, that 80% of the insulin-stimulated glucose uptake occur in the muscle. And for the type 2 diabetics, we of course see they are insulin resistant. The overall glucose uptake is of course reduced in the patients with type 2 diabetes. But what we also want to highlight here is that the majority of the glucose uptake still occur in the muscle. So therefore, we and several others believe that muscle play a major role in regulating not only glucose metabolism in the muscle, but also at the whole body level. So as I mentioned earlier in my introduction, impaired insulin signaling is tightly associated with insulin resistance. In the muscle, we and several other groups have shown not only at the level of AKT, but also upstream to AKT, for instance, IRS1 and PI3 kinase, and enzymes involved in the glycogen synthase and glycogen synthesis, and reduce AS160 and GLUT4. All these key molecules are actually reduced in the insulin-resistant muscle. Again, linking very clearly that the muscle play a key role in regulating glucose homeostasis. And of course, in muscle, you only not see impaired insulin signaling, reduced glucose uptake, but of course, there's also several other mechanisms contributing to the insulin-resistant muscle, for instance, mitochondrial dysfunction. So another organ which is also very important is actually the adipose tissue. So the main function of adipose tissue is to store fat or lipids. So when the adipose tissue becomes insulin resistant, which means that you will have an expansion of the adipose tissue via hypertrophic mechanisms, which causes decreased expression and secretion of a molecule called adiponectin. So adiponectin is a insulin sensitizing molecule actually. And during insulin resistance, you also see enhanced pro-inflammatory cytokines, and importantly, you see enhanced lipolysis. So because of enhanced lipolysis, you will of course have increased free fatty acids level in the blood. This will of course lead to glucotoxicity and lipotoxicity. Because you can't store the fat in the adipose tissue, now the fat must be stored elsewhere, and it could be the liver or the muscle. Of course, this is not healthy, but overall you see reduced glucose uptake in the muscle. You see impaired insulin secretion from the pancreas, but because of you have decreased or reduced insulin secretion, now we have another hormone which will be activated, namely glucagon. So glucagon will then promote the hepatic glucose production via gluconeogenesis, and now the liver also becomes insulin resistant. So now I will just briefly mention the mechanisms or the possible mechanisms of beta cell dysfunction. So as I mentioned, mitochondrial dysfunction could also play a major role in the impaired insulin secretion. And other mechanisms that may also contribute to impaired insulin secretion is ER stress. But of course, also mutations in the potassium channel may also impair the insulin secretion. So mitochondrial dysfunction does not only occur in the muscle, but also in several other tissues. So I mentioned very clearly that in insulin-resistant conditions and type 2 diabetes, you have reduced insulin sensitivity and reduced glucose uptake. Of course, the mitochondrial function and content has also been suggested to be reduced. Interestingly, with exercise, from a muscular perspective, we have seen, and several others have shown, that exercise not only increased the whole body insulin sensitivity, but also increased the muscle glucose uptake, and the mitochondrial content and the oxygen capacity is also increased. Importantly, PCSK1 alpha, which is a key transcriptional factor regulating mitochondrial biogenesis, has also been shown to increase with exercise. Therefore, it's recommended, because of these beneficial effects, that patients with type 2 diabetes are more physically active. So this is quite a busy slide, but I just want to show you that hypoglycemia does not only affect muscle or adipose tissue or the liver, but it affects or impacts the whole body metabolism, and several organs are of course affected. And of course there are some anti-diabetic drugs that are known, and I just briefly want to mention how they work. So metformin is a widely known drug, anti-diabetic drug, which main function is to decrease the hepatic glucose production, thereby leading to reduced hypoglycemia. One mechanism how metformin works might be due to the involvement of AMP kinase, but this is still debated. Another important drug I want to mention is the GLP-1. So GLP-1 is an incretin hormone which has shown to increase the insulin secretion. And it has also shown that GLPs work by decrease the glucagon secretion, thereby reducing the increased hepatic glucose production, thereby leading to reduced hypoglycemia. And we also have a PPAR gamma agonist called TZDs, which are known to promote adipogenesis. So TZDs have also shown to increase the adiponectin level, reduce the lipolysis level. Of course, then you will have the less free fatty acids in the blood. And interestingly, this anti-diabetic drug has also shown some positive effect on the muscle, because it seems that it increases the muscle glucose uptake as well. And the final one I want to really highlight is the SLT2 inhibitors, which also are widely used. So here, the function of this drug is to really decrease the glucose reabsorption. So now I want to summarize some of the comparison, the differences between the two diseases. So type 1 diabetes, which is diagnosed early in life, you see late debut, but that late debut is not uncommon. Whereas in type 2 diabetes, it's diagnosed in the adulthood and rarely in the children. And you clearly see in type 1 diabetes insulinopenia. In type 2 diabetes, we clearly see that hyperinsulinemia due to the insulin resistance. And later in the disease progression, insulinopenia may develop with time. And generally, it's not associated with obesity for type 1, but type 2 diabetes is typically associated with obesity and the muscle dysfunction phenotype is much more pronounced in the type 2 diabetics. Insulin is essential, occasionally not needed for a short period after diagnosis. For type 2 diabetes, lifestyle and polypharmacy, as I mentioned earlier, and sometimes it's possible to come off diabetes medications. For type 1, insulin given as injections or via insulin pump, whereas in contrast for the type 2 diabetics, disease control can be some degree personalized and may involve insulin. So now we move on to the, I guess, your favorite organ, namely the bone, and Morten will talk about the bone and diabetic complications.
Yeah, so thanks for that, Rugivan. Now we're moving to the osteocentric universe, which is where I feel at home. But I thought it would be really good to have a good overview of what is sort of common knowledge within diabetes, because that's a key part of this research area. Now, the question is are fragility fractures a complication to diabetes? Now, fractures are extremely common, both in men and women. More common in women, though, than men, but they do increase with age, and they pose a massive problem to human health. Next slide, please. And there are several studies showing that that fracture rates are increased both in type 1 and type 2 diabetes. I could have mentioned a number of different studies, including studies from this country by Peter Vestergaard and other countries, but I decided to go with this one, which is a very recent one from Sheffield, from Richard Easter's group, where they did a meta-analysis on published data, and they reported increased risk of fractures both in type 1 and type 2 diabetes. Now, the risks of a hip fracture is substantially larger in type 1 than type 2 diabetes. But even though the risks are not massively increased in type 2 diabetes, we have to remind ourselves that there are loads of patients with type 2 diabetes. So this is a massive problem. Now, one of the key things is that hip fracture rates seem to increase earlier in patients with diabetes than non-diabetics. So why is fracture risk increased in type 1 and type 2 diabetes? Now, for those of us that are interested in bone, we usually return to the basics of bone biology when we need to address the causes of a skeletal disease. And we then always go back to bone remodeling. And of course, that's a key thing, but for those of us not familiar with it, it's very important to remember that bone is remodeled throughout life. It's a highly coordinated process whereby osteoclasts remove old bone and new bone is formed by osteoblasts. As you can see here on the left side, there is both cortical and trabecular bone, and the trabecular bone in the femoral bone, as you can see, is more metabolically active than the cortical bone, but both tissues are remodeled. There are a number of minor differences between the remodeling activities in the trabecular and the cortical bone, and you can see some of it on the right side. The key thing, though, is that you need osteoclasts, the precursors of osteoclasts, to be present on bone. They will then start resorbing bone, which will be followed by formation of new bone by osteoblast. Then the matrix formed is mineralized and new bone is formed. So this is a process that goes on, and a lot of different activities can change this balance between formation and resorption of bone, causing either an increase or a decrease in bone mass, and ultimately changing the risk of fractures. Trabecular bone is one thing, cortical bone is another thing, as you can see in the lower panel. There's a kind of a cotton cone that drills a hole like we drill tunnels between the continent and the United Kingdom. And here the blood vessels allow precursors of osteoclasts to get to the bone surface, that then remove the bone, and that is followed by recruitment of osteogenic cells that can come from blood or from a blood vessel, such as pericytes. And when the number of cells is substantial of a certain degree, then they will start forming bone, and the bone will be new bone will be formed. But diseases affecting bone and diseases affecting vasculature can change this balance. Right. So in a clinical setting, we usually turn our head towards bone mineral density when we have a patient that has a fragility fracture, because we want to assess if they have osteoporosis or any condition related to low bone mass. So we do a DEXA scan, which usually produces a measurement of bone mineral density both in the hip and the spine. And based on that, we then usually come up with our diagnosis of whether or not the patient has diabetes. And we use the measurement to basically to assess the fracture risk in the individual. So below a certain threshold, the patient has, in the absence of vitamin D deficiency, osteoporosis. We also use the scan to assess treatment effect, usually at least. Now, in type 1 diabetics, bone mineral density tend to be decreased, whereas it's normal or even increased in patients with type 2 diabetes. So on the right panel, you can see data from Ann Swartz's study from JAMA in 2011, where basically the key thing is that it's shown that fracture risk is increased in type 2 diabetes, both in hip and non-spinal fractures, and that insulin may have an impact on the risk of fracture, at least for some fractures, increasing the risk. So increased fracture risk in patients with diabetes, and as you can see on the right side, the risks are higher for any given T-score in diabetics. Right. So how come that fracture risks differ between type 1 and type 2 diabetics? Well, this is a study from Richard Eastill's group. There are several studies investigating peak bone mass, but this one shows what I wanted to convey to you. Now, during childhood and adolescence, we expand our bone and increase our bone mineral content. And any condition, at least in theory, that influences the increment in bone mineral content or bone size could have a bearing impact on what happens in later life. So one could speculate that a disease such as type 1 diabetes could have a deleterious effect on bone mass in later life if it debuts even in childhood. This, of course, is contrary to what is seen in type 2 diabetes, which at least at present is something that mainly is seen in adults. Now, another approach to looking at investigating bone is to look at bone turnover. And one approach is to measure biochemical markers of bone turnover. These markers reflect sort of the whole body bone turnover, both for resorbed bone and formed bone. And two markers that we generally tend to use are P1 and P, reflecting formation, and CTX, reflecting resorption. And for those designing studies that includes bone turnover markers, I'd highly recommend that you read the paper by Richard Eastill down below, because it does come up with some suggestions as to what to be aware of when you do measurements of bone turnover markers. So these biochemical markers are very sensitive to a number of different things. For instance, if you eat something, CTX drops dramatically for reasons that remain slightly obscure. There's a certain circadian rhythm to these markers, so they will be low in the afternoon. Therefore, they need to be measured at the same time point, preferably in the morning. Now, there's also a difference between sexes. So levels are higher in young men, and they're also higher in infants. In diabetics, there have been done a lot of studies of the turnover markers in diabetics, and these have been compiled in the study by Rugivan in European Journal of Endocrinology just a few years ago, where they show that CTX is decreased in both type 1 and type 2 diabetes, reflecting lower bone resorption. Another marker of bone formation, osteocalcin, is decreased as well, and they report that P1 and P is decreased in type 2 diabetes, reflecting lower bone formation. There's not, in this study at least, any convincing change in type 1 diabetes with regard to P1 and P, but that has been shown in other studies. Right. So next step could include, of investigation of bone, could include high resolution peripheral quantitative CT scans. It's not available everywhere, but there are lots of places in Europe that have access to this machinery. And my colleague Vikram looked at type 1 diabetics just a few years ago, and he observed that there's a deficit in the cortical volumetric bone mineral density and thickness, but only in the distal radius. And he then looked at whether there were any sort of differences between the patients with diabetes, including this study, and observed that microvascular disease associated with a pronounced deficit in particular the cortical bone, cortical porosity, that is something you can see in these green dots down below. Now, when it comes to type 2 diabetes, there are several studies using this machinery, and the general thing is that the investigators have reported increased cortical porosity, including those with microvascular disease, indicating that type 2 diabetes may have a particular bearing on cortical bone, which could reflect an impairment in bone strength, and then perhaps explain why fracture risks are increased in patients with type 2 diabetes. So next step is bone biopsy, and bone biopsy is something that's not done in everyone, and it's something that most patients would like not to have done. But we do use it occasionally in clinical settings and for research purposes. And the reasons for doing a bone biopsy is to assess the bone formation and the structure of bone. So if we do a bone biopsy, we can then have the opportunity to look into whether or not bone formation and resorption is normal in these patients, and whether or not bone cells seem to be present in a normal number, and whether they are active or not. So this is a cumbersome procedure because it includes labeling of bone with tetracycline or demiclocycline ahead of the biopsies. And it also calls for a very good specialist in dynamic histomorphometry, because it is a tricky thing to investigate bone tissue. We still need to learn a lot more about the histology of bone to be sure that we have a good grasp of the bone phenotype in type 2 and type 1 diabetes. And we are also slightly short on knowledge about the bone cells, including mesenchymal stem cells from patients with these diseases. Right. So when we turn our heads towards the pathophysiology of diabetic bone disease, it's very easy to get confused, and it's very easy for those of us that like bone to get excited. This review, which I highly recommend, it's written by Nicola Napoli, and loads of very good research within this area, clearly demonstrate some of the factors that are changed or could be explaining the reasons why bone is changed and fracture risks are increased in diabetes. I can't go through all the mechanisms. I would like to highlight just a few of them. Now, on the right-hand side, you can see hyperglycemia. That, of course, is something that's shared by both type 1 and type 2 diabetes. And hyperglycemia may have a direct effect on bone cells, causing them to be less active, to impair osteoblast differentiation, to impair osteoclast activity as well. Now, another thing to consider is sclerostin. Sclerostin is secreted by osteocytes and to some degree osteoblasts, and it's an endogenous inhibitor of Wnt signaling. Binding to LRP5, it prevents Wnt signaling, causing a decrease in bone formation, while at the same time bone resorption may continue. So increased levels of sclerostin may cause a decrease in bone formation. And with a decrease in bone formation, we will, through coupling, have a decrease in bone resorption. So that can contribute to the lower bone turnover observed in diabetes. So these are just two of the things. I'll come back to the incretin hormones later on. Now, as I mentioned before, one may have to consider that the debut of the diseases differ substantially, with type 1 being diagnosed early in life and type 2 usually in later life. Although we now have regrettably a lot of patients with type 1 diabetes who are obese and may have a type 2-ish phenotype along with the type 1 diabetes. And we may have people that have type 2 diabetes that may have autoimmune disease as well, causing type 1 diabetes, it's still very important to try to consider the differences between these two diseases, because that can perhaps explain to some degree why they cause increased fracture risk and why they differ with regard to, for instance, bone mineral density. So type 1 is diagnosed in early life usually, and it comes with a number of other things that can impair bones, such as autoimmune diseases, hypogonadism, vitamin D abnormalities, etc. Type 2 diabetes is, as Rugivan mentioned before, a somewhat more complex disease because it includes insulin resistance. So although it hasn't really been, at least not to my knowledge, been confirmed in human samples, insulin resistance could play a role in bone, causing a decreased sensitivity to insulin in bone cells, and that could then lead to a lack of the anabolic effect of insulin to bone, causing lower bone turnover, theoretically at least. But on the other hand, type 2 diabetes often occurs with obesity, which increases mechanical loading that should have an effect on bone. Then again, it could also cause fractures of different sorts of fractures that are related to obesity, mainly, rather than type 2 diabetes. But obesity comes with loads of problems, including inflammation that can have a deleterious effect on bone turnover and bone strength. Now, one of the things that I mentioned before was microvascular disease. Of course, we know there are a number of different well-known complications to diabetes, and that they include microvascular disease. And at least in theory, and that's what we are pursuing in our unit in Odense, microvascular disease could contribute to the risk, the increased risk in patients with diabetes, because microvascular disease could prevent the recruitment of osteogenic cells to the newly resorbed bone areas, and it will at least prevent oxygen and different types of nutrients to get to the bone cells where they should be active. So microvascular disease could have a particularly deleterious effect on bone, perhaps more so in the cortical bone than the trabecular bone, as indicated by increased cortical porosity in the HRP QCT scans. It is something that hasn't really been corroborated yet. So what do we do then if we have a patient with diabetes who sustains a fragility fracture? Now, in the clinical setting, we usually have just two approaches, basically. Either using an anti-resorptive drug that inhibits the osteoclast and in turn the osteoblast. And they include mainly alendronate and resitronate that both increase bone mineral density in diabetics. We also have zoledronic acid, but we lack knowledge about the effect on bone mineral density. And then we have denosumab. And I was happy to note that there's a fairly recent study reporting that in diabetics, denosumab, the rank like inhibitor, is equally as effective as in non-diabetic to increase bone mineral density in the spine and also to reduce vertebral fractures. So denosumab seems to be uses denosumab in diabetes seems to be supported by very good data. When it comes to the other approach, we have the opportunity to use various anabolic drugs. Very recently, the number of drugs was increased in the European Union to 2 drugs, allowing us to use both tirperatide, the PTH receptor, PTH analog, and romosozumab, which is a sclerostin inhibitor. And there are a number of studies looking at the effect of tirperatide on bone mineral density and vertebral fractures in patients with diabetes, and one of them reported by Bente Langdal and a lot of other co-authors demonstrated that tirperatide is effective in preventing fractures in patients with diabetes, perhaps more than in non-diabetics. Now, when it comes to romosozumab, we're slightly short of data yet, and that's a little bit of pity because with higher levels of sclerostin, it could be perhaps the drug to go for. However, romosozumab does come with a warning, and we are probably not going to use it in patients with existing cardiovascular disease or stroke, at least not in this country. And so it may not be the drug of choice in patients with diabetes, at least not as knowledge stands right now. We have other possibilities, such as the SGLT2 inhibitors, They are reported to increase bone resorption slightly and decrease 125 vitamin D, but fracture data are very inconclusive, and actually the drugs seem to be fairly safe with regard to fracture risk. Just one of the drugs, canagliflozin, seemed to be perhaps increasing the risk, but not in all studies. There are a number of new studies on the horizon, one of them being GDF15 analogs. They're very effective, it seems, to reduce body weight, but they do seem to come with a risk of increasing bone resorption. Very recently, there was a study by Bonnet reporting that denosumab could actually increase insulin sensitivity. And that, of course, is something that's particularly interesting and could suggest that this drug would be superior in patients with type 2 diabetes. There are a number of different approaches to treating diabetes, in particular type 1 diabetes, and that includes closed-loop systems that improve delivery of insulin and may prevent hypos that can cause falls and fractures, and may also be able to increase the amount of insulin given to young people, and then perhaps we could have the benefit of the anabolic effect of insulin even in youngsters, and that might increase peak bone mass. Speculation, but still. And then there are a number of different drugs emerging, one of them being GIP, gastrointestinal peptide, bound to oxyntomodulin, that does seem to prevent loss of bone, even though the combination promotes weight loss. And finally, we have the incretin hormones mentioned by Rugivan that generally cause weight loss, but there are some studies indicating that, that despite the weight loss, there's no loss of bone mineral density. Fracture data are not really supporting that they're beneficial to fracture risk, but it's perhaps not really clear yet whether that's true or not. Now, incretins include a number of different drugs on the market, and it's an area that's expanding quite dramatically, because these drugs are used not only for type 2 diabetes, but they're also used for obesity, and they are being promoted as treatment of NASH, one of the new areas for the pharmaceutical industry. They're secreted by the gut when we consume nutrients. We know that consumption of food does have an effect on bone turnover markers, with CTX dropping, as I mentioned before, and that could be explained perhaps by some of the incretin hormones. They do seem to have at least an indirect effect on bone, acting via their promotion of insulin, but they also seem to have direct effect on bone turnover, with GIP promoting bone formation and inhibiting bone resorption. Data for GLP-1 is a bit less sort of solid, but this hormone seems to promote bone formation. And in vitro, it seems to be increasing bone resorption. Now, in the future, we might see drugs that combine GLP and GLP-2, and there are companies pursuing combinations of GLP-2, which is an anti-resorptive drug, and GIP. So it may be that we, in the future, will be able to use these drugs for the treatment of bone disease and diabetics. And that brings me to an end. This was a very brief overview of diabetes and bone. We wanted to introduce those not familiar with diabetes and not familiar with the very basics of bone to the area. We hope that you have some questions, or that we could connect after this meeting, either on Skype, email, or in any other way. Yep.